Thank you for the invitation. I'm going to talk about a project that we've been doing based in Cambridge to really pilot thinking how we're going to provide rapid sequencing for severely ill children, both in NICU and PICU. And in particular, we need to think about this within a national health service and trying to provide some affordable version of this platform. So this is hardly the audience to inform you or well informed about how common rare diseases are, but actually I think we're probably less clear about how many children die within the first year of life. It's like 35% of children die within the first year, and a further 30% then die within the first 5 years. So there's a very large proportion of rare diseases that are presenting extremely young and have a very poor prognosis, and we need to start thinking really a bit smarter about early diagnosis and therefore treatments. And of course, these are relatively jointly are common. So in the UK, we have just over 500,000 deliveries per year, and a significant proportion of those, about 95,000 of those, will attend NICU and PICU. They may not be there long. There'll be a few that sniff a bit of oxygen and do very well and go home, but there are very many children who are spending large amounts of time in this setting. So improving the diagnosis will potentially inform clinical management within that setting, and also will create this cohort of children that we should start thinking about adequately powered clinical trials and treatment options. And also we need to think about the quality of life for some of these children and whether having more information towards the families and the parents will then help enable them to make informed decisions about treatment options. So to be honest, when we started this, we didn't really know who to sequence and who to recruit. And so I suppose the posh version of that is we were relatively unselective. And we essentially chose or felt that we should look at those children where we thought there would be a Mendelian cause of disease. And so we excluded those who were premature but otherwise entirely fine, and obviously we excluded those that already came with a known diagnosis or had a diagnosis by another route. But we included pretty much everything else, to be honest, and particularly those who had structural abnormalities at any level. We initially sequenced quite a number of children who had HIE, and we also considered virtually all children who presented with seizures in the neonatal period or in PICU. Those with dysmorphic features and structural abnormalities, including quite a number of children with congenital heart disease, but often in a syndromic form, and also the suspected metabolic. We did do initially quite a few children with NEC, but there were children who were slightly surprising with NEC. They were having a slightly unusual clinical course, and we did some children with chronic lung disease, and also those with extreme failure to grow. We also had this lovely category, which was sort of that shrug of a shoulder in PICU and NICU, where somebody says, this isn't quite right. It's not what we normally see. And we reserved the right for that slot, because I think it was proved to be very useful. So Cambridge runs a regional genetics unit, but it also has a regional PICU and NICU, and so our catchment area is several million, and these are reasonably sized units by UK standards. There are 40 beds and fitted. And so essentially we approached approximately 10 to 15% of the cohort of children or parents of children who are attending these units. Initially, we approached families, and then from our initial cohort that we did, we had nearly 45% said yes straight away, with relatively little discussion or angst. They were very clear that they wanted to find a diagnosis. They saw that this was a possible route to a diagnosis, and they were also a huge level of altruism interesting. People were often clear that they were very happy to take part. They didn't think they necessarily would benefit from it, but they were very keen to help others who were in their situation. We had a very clear, relatively modest group who very clearly declined testing or being part of the study, and the general theme was that they just were totally overwhelmed with what was happening. They thought their baby was going to die, and they just couldn't cope with any further decision-making, or they just weren't keen. Interestingly, some had very clear views that their child did not have a genetic condition. And I wasn't quite clear what that was meant, but certainly, and a significant but small group who are concerned about testing that might label their child inappropriately. And then we had a large group of other, which is really an interesting group. Neonatal care, children come in, come out, go to other hospitals. So there was a very large proportion of children that really didn't stay long enough to parents make a decision, so they were effectively lost to follow-up, and some were discharged. But there was a significant number who were interested, but actually never said yes. And I suspect that's an interesting group who just couldn't quite deal with saying no to the very people who are dependent on keeping their child alive. We were extremely lucky. We were able to negotiate with our ethics team to have a two-tier consent, and we were very clear that for some subgroup of patients, they are in extremis, and having a long IRB 9-page form was completely inappropriate. So we had a light touch consent form, and in the early days we used that quite a lot. And essentially it said, we will find the cause of disease if we can, we'll feed it back to you, and we'll be back in touch with you pretty soon because we'd like to do a longer consent for more extensive research. And certainly in the early days we used that quite extensively, but as we as a professional group have matured and the people who do the consenting have matured and more confident, actually we much more often go straight to the full consent form now because people are much more familiar. And so I think that's quite a useful learning for us. In this study, we were very clear with the families what we would and what we would not feed back, and we were very clear we would only report back pertinent findings, and in fact we would only report back pertinent findings that we were reasonably confident that these were the cause of the disease of the reason why the child was presenting. I think that may also account for some of the reasons why we had quite good buy-in. It was a very straight contract, we'll try and find out what's wrong with your child and we'll feed you back that and not much else. We chose to use a trio strategy. Probably most people are very familiar with this. And our hypothesis was that these are often reproductive lethals, and therefore it's highly likely that there will be a significant enrichment of de novo variants, and therefore trio analysis was an appropriate course of course. It also, we felt it would probably be quite helpful in distinguishing cis from trans variants, which can be difficult if they're not close together, and that's certainly true. And we were also clear by doing a trio analysis, we reduced the possibility of incidental findings because most incidental findings are familial and adult onset. So by not reporting familial variants or not even seeing them because essentially you're filtering them out, we avoided actually seeing many of the variants that would be incidental. We chose a gene agnostic approach. We have done the whole genome and we have not excluded any genes and we don't whitelist genes or blacklist them. And so in a single pass, we're doing 30x coverage of the nuclear genome and about 1,000x coverage of the mitochondria. This has meant that in a single pass, we've been able to really do an extensive analysis of the genome, in particular areas that are notoriously difficult to sequence by an exome pipeline, and that's namely those with a very high GC content, and also we've been quite successful in looking at CMVs. And so we also wanted to do a comprehensive analysis because we weren't actually sure whether there was a subset of genotypes or genes that would be manifesting in a neonatal period that are not normally recognized elsewhere. So this is our workflow. It was a genuine collaboration between the NHS in blue and the academic team in red. Debate whether the red team do the most dangerous bits, who knows, maybe we're dangerous. So clinicians identified the patients in NICU and PICU, they discussed them with us and discussed with our key recruiting person, and there was a broad discussion, but the discussion was usually fairly brief. Are they eligible? Would you like to do this? We did not make a meal of this, we made it very brief. If they were eligible, they were then approached by the research team. We left information on the COTS, we left time for the families to discuss. Some families spend a lot of time in NICU and PICU, so they spent, and then we came back to them on an iterative basis. We found that those families that we'd sort of seen or said hello to about 3 times, that was enough. Beyond that, we would not reapproach them. We did not want to coerce them. And once they did consign a consent form and they consented, this was logged in our hospital record, in our electronic health records. So they were allocated a number there, which then it meant that it flowed through all their sample logistics processing. DNA was extracted in an accredited laboratory in the diagnostic service, and it was plated and QC'd and dispatched to Illumina. Illumina did the sequencing at their accredited pipeline in Cambridge, or just outside Cambridge. The variants were then, BAMs and also the VCFs were returned to the research team, who then provided annotation as part of the virus source I mentioned. So this is a separate project from that, but we used the 13,000 genomes as our reference annotation. And also we looked for annotated with ClinVar, HTMG Pro, and also our internal filters. We then filtered, and I'll talk more about that. Any candidate variants or interesting errors were discussed jointly between the clinical and the research team, and then we proceeded to confirm within the NHS. And in most at the moment, we've still Sanger confirmed all our variants, but so far so good. We've not missed or done anything wrong. So this was, we set ourselves the task that in the UK NHS service, rapid arrays is, I think it's about a 2-week turnaround. That's the sort of standard of practice. So we set ourselves a target to be in that order of magnitude. So we would be comparable with the routine array analysis. We were pretty bad at it at the beginning. We were pretty hopeless. We took a time. We know inevitably we started before we were really ready. You know, our enthusiasm took the better of us. But gradually we've honed and thought, and actually in some ways was helpful that we learned and practiced where were the pinch points, where were the pits. And then gradually over time, we have now got ourselves down to a pretty much steady state where we are essentially, once we have a trio, we are delivering a result, a preliminary research result, within 2 weeks, which is then confirmed. And this is now holding pretty steady. And in fact, interestingly, now our rate limiting step is in fact the sequencing step at Illumina. So we've done 350 trios, but this data is based on 320 trios over a period of time. We were very clear that we wanted to have trios, and we were incredibly lucky and very fortunate. I think actually the dedication of the people involved in the study of getting trios and getting parents. And many families are still, they're still separated even by the time a child is born, and we've been very successful in getting samples even in families that are no longer living together or nuclear families. But often people are prepared to give a sample for the sake of making a diagnosis in the child. But essentially we have a very significant number of trios and also occasionally additional siblings. But of course occasionally we have singletons, we have egg donors, we have sperm donors, we have duos, and occasionally it's not possible. So we've done. Our average age has been 1 day up to 17 years, PICU and NICU, and the median's about 106 days. But at NICU, a significant number of those are significantly premature. So a bulk of our recruitment is in NICU, and 1 month to 2 weeks of age is quite usual, through to much older. So our pipeline, we inevitably are always trying to improve. Initially, we had the reads from Illumina, where we look at SNVs and indels, and we've done structural variant calling using Manta and Canvas. And then gradually over time, we've improved it to look at, we are now calling mitochondrial variants, uniparental disomy, but not systematically, only in areas of the genome where it has previously been reported that that is the cause of disease. And we are beginning to use expansion hunter and looking at STRs, and more recently we're trying to look at SMA and try to call straight from genomes SMA areas. As I say, those are annotated and they're frequent. We're using standard filters that most other people are doing based on frequency, mode of inheritance, segregation, and we then provide a list of candidate genes. So the yield varies depending on what your setting is. We've now done 90 probands at least. The general trend is that in NICU overall, the diagnostic rate is about 18%, but it's quite skewed to those in their very early days of existence, so 0 to 10 days. Whereas the slightly older children who are living a long time in NICU are a lower diagnostic yield. For PICU, so pediatric intensive care, so these are children who've gone home and come back, so some of them can be still very, very small. And then there are the children who come in with dramatic events suddenly going off or often requiring ventilation. And the diagnostic yield of 28% overall is really quite high. Many of these children are also under paediatric neurology, so some of these are enriched for those with paediatric neurology. I think of interest and comparison, and interesting, once we started doing the NICU and PICU project, we then started getting inundated by my genetics colleagues and the paediatric neurology colleagues saying, actually, these children are just as urgent. There are decisions that need to be made for them that are clinically important, so can we do those as well? So we've done some, and interesting, the diagnostic yield is slightly higher, perhaps because they've had a longer time to present or mature in their phenotypic spectrum. We were right in our guess that de novo variants are by far the most common cause of disease, and so we only are reporting back pathogenic and likely pathogenic. And when we started, we were very strict, and we said we would only report pathogenic and likely pathogenic. But of course, there's inevitably slight creep. And that creep has actually been not in the neonatal group, it's been the creep in the pediatric group, because if they had not been in paediatric intensive care, we probably would have reported some of these VOSs. And then these are the VOSs that are what we would call the sort of hot three. These are the VOSs that if you report, perhaps as a functional study, perhaps as a metabolic study that could be done to try and help resolve whether these are VOSs or not. But as a general rule, the VOSs that you don't really know what to do with are not being reported through this pipeline. So certainly high numbers are de novo, and a reasonably high number are recessive, both consanguineous and homozygous. In our region, we do have some consanguineous families, but we're not a massively enriched geography for consanguineous marriages, but there are some founder mutations that we've seen, homozygous variants, and a significant number with X-linked disease, but also quite a few mitochondrial variants and a couple of inherited variants. In the very early pipeline, we never looked at inherited variants, and we missed Noonan's, where the mother was totally unaffected. So we now sort of whitelist, based on the HPO terms of the child, whether there are variants that we will specifically look for in specific genes that we think could be the cause and could be familial, because we're slightly embarrassed by missing something so obvious. The variants were there, it's just we'd filter them out. So lots of cases of mitochondrial metabolic disorders, so about 16 cases, and some of these, and many of these, sadly go on to die. And I think what we're picking up is a group of patients that previously probably weren't sequenced, because by the time standard investigations had been done, then we hadn't really thought to do such a comprehensive investigation. Perhaps not surprisingly, we've also picked up quite a lot of children with EIE encephalopathy, but there is a really wide range of neurodevelopmental disorders and neuromuscular disorders that we've picked up, both neurodegenerative, neuropathic, myopathic, a couple of cases of SMA, muscular dystrophy, Rett. But we've also, because we are doing whole genome sequencing now in parallel with quite a lot of standard of care, we're picking up some complex structural rearrangements, which actually turned out to be extremely interesting because we're able to resolve them much more effectively than you can from a standard array platform, and a whole miscellaneous group of other conditions. So the message for that is that there's a hugely wide range of molecular diagnoses, and we have very few repeats. There's not really a hotspot in the sense of presenting. We have a couple of skeletal dysplasias. We have a couple of children with ARID1B. Perhaps that's not surprising. One was associated with a significant chromosomal abnormality. And of course, perhaps not surprising, we've got a few cases of Dravet's or SCN1A. But the message is you need to look at the whole genome because there are such variation in presentation, and therefore a panel would be tricky. We do use a panel if we have only got a singleton, but our panel is well over 1,000 genes. So it is a panel, it's not adult onset diseases, but it is very extensive. So one of the questions we wanted to ask, which was based on our ignorance, is how well does the phenotype predict the genotype in these young children? Is OMIM, all our knowledge or our literature knowledge that we know about many of these Mendelian diseases, is it applicable into the neonatal period or the neonatal presentation? And yes, it is for some of the old golden oldies that we've known for quite some time. People are really good at clinically making a charge diagnosis. But sadly, and so what we did in order to do this correlation is we took all the OMIM genes, we ranked them based on their phenotype and asked the question, how likely was the gene that we found really going to be the cause of the disease if you ranked them in OMIM? And for these were all in the top 10. The slightly depressing moment was when we realised that by far the most of these genes that we found the cause of disease in, the phenotypes and the HPO terms that we'd listed were not good predictors of whether it was the gene, this was likely to be the gene of significance. Partly because some of these genes are relatively new, so there isn't the body of data, but the other likelihood is that the phenotypes in the neonatal period are rather different. But we did phenotype very well and very extensively, so this isn't because we were being lazy. So our median HPO terms was 11. And we looked at those that we found diagnosis with and those that we didn't, and the answer was pretty much the same. So it wasn't a failure to phenotype. It looks like the phenotypes are slightly different. And we had a very wide range of phenotypes, so we took as broad an approach as we possibly could, and we were as detailed as we possibly could be. So what we did do is look at those where we did get a diagnosis and say, well, is there any crude enrichment? Is there a slightly, which of the phenotypes that we should be are sort of flags? And so what we did was did a phenotypic comparison. We took two different probands, we compared their phenotype, and we looked and numerically created a sort of phenotypic similarity score in those that we found the answer. In NICU, we didn't really establish any headline phenotypes. Those with congenital heart disease were fairly good predictors that we would find a gene abnormality, but actually if you look at some of the genes that we found, they're not classic congenital heart disease genes, it's that these are syndromic conditions of which congenital heart disease is quite a common feature. And we did, children who had significant growth impairment or growth abnormalities were also quite good at predicting, but and those also with epilepsy, but it wasn't really that systematic. And in fact, but in PICU it was a little bit more predictable. Those with a neurological phenotype, those with muscular problems, they were the highest group for a diagnostic yield, and they were highly predictive of being able to find a diagnosis. So if you have a dysmorphic child, then you're in good ground. You're probably going to have an increasing diagnostic yield. And of course, this may be a circular argument. These are the genes that we've known a long time, and these are the genes that we're going to be picking up. There's still, despite all our knowledge, there's still areas where we are still short of gene knowledge about genes that cause disease. And again, the theme that in PICU, neurology was a very good predictor. So if you did have dysmorphic syndromes, dysmorphology, you were really quite enriched for having a diagnosis. But if you didn't have and there wasn't any obvious documented dysmorphology. And similarly, if you do have neurological features, this was reasonably well predicted in both, but it wasn't so significantly different. So why are we doing this? Is it making any difference to our clinical practice? And much more importantly, probably, is this making any difference to our families? And I think I can very confidently say, yes, it is. It's making a huge difference. Much like the Australian data, although they've got very beautiful data that they've done probably a much more sophisticated analysis than we have done. The theme really is that for the older children, they were already often being looked after by a specialist already, and so the existence of a diagnosis didn't change the specialty you went to, but it significantly changed what additional testing you would have and the nature of the conversations that you might have in clinic with those families. Whereas for the younger children, having a diagnosis meant that we could then direct children to a specialist care, which was more appropriate, more focused and more directed to the specific needs of those individuals. Did we modify treatment? To be honest, relatively rarely, but this again is a bit of a circular argument. Until we make these diagnoses and start doing really good, powerful clinical trials, we're not going to be modifying treatment at a very significant level. We do have some nice examples with SCN1A, where we have altered medication according to mutation and having some nice clear differences. But to hand on heart, have we dramatically changed treatment? Not yet, but these are early days, and that's what we should start thinking about. I think I was quite surprised the degree of significant recurrence risks, the numbers that are recessive, and also how helpful actually knowing something was de novo was for some families as well. So we could define the recurrence risk as being modest for many of the de novo variants. And also interesting, we have been able to explain why many of these children have gone on to die, and this has been both useful for the families to have an explanation, but also for the professionals, so that jointly families and professionals can accept or acknowledge that they did the best they possibly could. I think paediatricians find it very difficult if a child dies in their care or in their hands, and it's been actually remarkably helpful to sort of give closure, and certainly one of our families very clearly articulated this recently about how helpful it was just to give closure despite the sadness of that. And of course, this does also link into that having a diagnosis can help with palliative care and supportive decision-making, particularly for the families making these very, very difficult decisions. So in summary of our pipeline, I will talk to you. These are the sort of areas that we've thought that, certainly rapid trios, and I would strongly recommend whole genome sequencing because of the copy number analysis that we've been able to do. It can be integrated into the existing healthcare system, and it doesn't need much DNA. We use the standard neonatal 1 ml tube, and that's quite sufficient to get DNA adequately for good coverage and repeat testing. Those children with a degree of dysmorphism and neurological features are at an increased yield, but the important message is actually they're very difficult to stand at the bedside and say, it's that gene. Those days are going. It could be one of many hundreds of genes. And we are really got some quite powerful data to suggest that the phenotypes are not quite the same as the matured phenotypes that you'd see in a pediatric neurology clinic or a clinical genetics clinic. And I think the other thing that we've learned is that we've done continuous reanalysis of these families, and we found many new diagnoses that we had missed before, not because the variants weren't there, but the publications were not there to suggest that this was a sufficient of a gene of significance. So in my last part, I want to talk about some case studies that we've done, and I will go through them just to illustrate some of the things that we've done, because actually this is quite challenging, and we've had many hours of lots of discussion, and I think our worry is we're going to do the wrong thing. So this is a particularly touching family. This family have had 2 babies, each of whom both died at day 1. And we started our project just as the second child was due to be born. And both children had a very similar phenotype, non-consanguineous family. The child had hyperplastic lungs, pneumothorax, talipes, sort of congenital arthrogryposis phenotype, polyhydramnios, and the problem at birth was real difficulties in intubating these children, and both children died. And we had a quad, we had both parents and both children, and performed whole genome sequencing. And we found a titin mutation, which you can imagine we all sort of groaned and thought, heck, if anybody's looked at titin, this is the decipher read of the titin. How on earth do you make sense of this? However, these are both frameshift variants, and they were in trans, and they were in both children. So there's proband and sibling inherited from father, proband and sibling inherited from mother. So we knew it was in trans, and we knew that these were frameshift variants. and both are located in the M line. So it took us some time. We were not that experienced. Others in the audience are probably much more experienced. That there is small print in the literature about congenital titinopathy. There's now since been a really lovely review bringing all this data together, but sadly we had to make the diagnosis without the benefit of that review. And these children, in fact, child 4 is a very similar story. Both these variants are in the M domain, and we think that these are likely to be truncating. And the phenotype was highly specific. So on the basis of that, we reported this back, but it was, as you can imagine, a nightmare. I think the thing you need to be slightly careful of when you're doing this is to make sure that your consent is sufficiently open. We made the diagnosis in a mother at the same time as we did with a child, carrier status in a mother. And I think perhaps we, in retrospect, as we learnt, this is one of our very early cases, perhaps we should have spent a little bit more time talking with the mother about making a diagnosis, potentially making a diagnosis in her. So this is a newborn baby. It was a prem, respiratory distress, but had very severe floppy infant with severe congenital myotonia and myopathy. This child was ventilator dependent and was completely dependent on the ventilator, had lower limb contractures, and went down the route of palliative care, was extubated and died in hospice in 24 hours post-extubation. This child had had multiple investigations, and this was one of our first children that we recruited. So this child went through the standard of care. So it's a really nice illustration of the standard of care. Had an ECG, had an MRI, had a muscle biopsy, had some standard testing, and also said, oh, let's put them into next-gen children. We were slow because this was very early in the days, and this child had a likely pathogenic in MTM1. As a myotubular myopathy. So yes, we made the diagnosis. We didn't make the diagnosis before management decisions were being made. I think in retrospect, we probably would have helped with the management and the decision making of more than 3 weeks on a ventilator, not having a diagnosis. And also there is now treatment options for this variant or this condition, and this child missed that opportunity to be recruited into a clinical trial because we were slow at that stage. But I think illustrates to us the direction of flow. And the mother is a carrier. I think that's quite hard when you know that your child has died, and by the way, straight away the same day you're being told you're a carrier, whereas perhaps a few days later or a little bit, well, let's do parental bloods, might have been kinder. This family have been very helpful, and they're happy that that had happened. So the next case that we did was a child with a very standard a phenotype at some level, microcephaly, refractory epilepsy, multiple seizure types, and came into PICU. Had a suggestion of a family history, quite a difficult family, child protection issues and care issues, so it was quite difficult to get a really good family history, but certainly some suggestion of a family history. And we found a variant in ARX, which was a very clear ARX variant. ARX is notoriously difficult to sequence, and it's hugely GC-rich. And in standard pull-downs of a standard exome, you hardly ever see ARX pull-down. You need to do special GC-rich content. Whereas this, you can see the gene overall, you're getting a really standard 30-35X coverage, which has been really great. This variant was in the child, a male child. It was from a carrier mother, and it's in the hotspot of variants, and it has been previously reported as pathogenic, so we were confident to report this. So GC-rich for content regions, and of course we screened all the other encephalopathy genes as well at the same time, which meant that we weren't doing a second tier of analysis. I think gene agnostic is probably the way to go, because I think this is an area where we're still on quite a steep learning curve of new genes that cause disease. And here's a nice example of that, where the child was born and there'd been some concerns about deteriorating neurological status, global developmental delay, speech and language, fairly non-specific, but there was concern about this child. And we were asked to do a trio genome, and we found a variant, a de novo variant, with a reasonably high CAD score in UBTF. Now, this is associated with neurodegeneration, childhood onset with a brain atrophy. The paper that defined this disease had been published 6 weeks before we did this. So a standard pipeline with a gene list would not have picked this up because it wouldn't have been curated. We wouldn't have had a versioning. We're doing this within literally, our analysis of the literature is post hoc, having found the variant. And the data at that point, that paper, it's an American Journal paper, very lovely paper with very good and clear evidence of 7 unrelated patients. They all have the same variant. It's a dominant negative. It's assumed to be a recurrent gain of function variant. And so we were able to, good functional studies published in literature, and we were able to confidently call this trio as a pathogenic variant, which would not have been possible if we'd spent hours and hours slowly creating gene lists. As you can see, the pathogenic variant. So this is a case of a child who, this is our child, who presented at 6 weeks or 4 weeks with a lactic acidosis. We performed a trio. We found a biallelic variant in NDUFA6. It was not in the literature. Thanks to Matchmaker, wonderful thing that is, instantly in Matchmaker, there was already a publication in progress. We slotted our family in. We spent a lot of time discussing how likely this is to be the cause of disease and how familiar, how similar these cases were together. New gene published, but actually the gene was still in final stage of review when we were able to offer a prenatal to this family because this previous child had died. So again, we are learning and observing new genes that cause disease. And finally, I think we're to talk about complex structural variants, which has been really interesting and fun. So this is a child who's presented both to NICU and is under the paediatric neurologists, who has multiple episodes of status coming in and long-standing problems, but there was concern to see if we could try and identify the problem. This child has a large terminal duplication, which we could sell. Because we're using a trio, we were able to phase and we were able to be clear that this is paternally inherited on the chromosome. And as you can see from the reads, we've got an evidence of a duplication based on the read coverage, and the light green is suggesting that these boundaries map through to chromosome 18, despite the fact that the origin of this is chromosome 10. When we looked into the duplication further, within that duplication there is a deletion and an inversion, and we were able to gradually play 3D jigsaw puzzles, as we all do, and to be able to try and define exactly what the nature of this duplication was, and it turned out to be both based a duplication with a deletion, an inversion, and a duplication, which you can begin to see by and these are on the paternal haplotype. So what we think is happening in here is that you've got wild-type chromosome 10 and wild-type 18, and you've generated a new 18 with a translocation. But there's both a duplication and an inversion in this. And so these are mechanisms that we think that may be happening. You're getting a chromosome 18, you're getting a duplication, an inversion event, a deletion event, and then a translocation event. So by having, even with a short read sequencing, we've been able to resolve some of these really complex structural abnormalities. And what we're seeing increasingly is that the array abnormalities may pick up the large deletions, but the breakpoints, there are very commonly inversions or small duplications at breakpoints that we are now beginning to resolve. So these are some nice examples that I think, we're beginning, technology is beginning to be available, and we're beginning to, in a single pass, begin to look at multiple different mechanisms of disease. We've got several examples where we've got CNVs on one allele in trans with an SNV on the other allele, and we have several examples with mitochondrial variant. And because we're doing trios, and I think it's probably more because we're doing trios rather than necessarily the genomes per se, we've got a couple of examples where we've seen trisomy rescue. There was confined placental mosaicism early on in the pregnancy with a mosaic trisomy 2. The baby was born, but there were additional problems that people were concerned about. We were able to do genome and could not find any additional abnormalities, but what we could see was evidence of significant trisomy rescue. And so it was UPT2, which is not what we often see, and also not what we would normally necessarily see from an array. So finally, this is a huge project. We are already beginning to having, as a proof of principle, doing this in the research domain. In the UK, we're aiming to start delivering this and offering this as a test by next year. And so there's a lot of work. And I think the message for those who are trying to do this, it's not the sequencing the difficult bit, it's ascertaining the patients, getting the consent, getting your trio, getting the feedback, getting the MDTs, and making good and safe calls. Thanks very much.